Okay, now in this part, we'll talk about spirometry and the different respiratory volumes. In order to record the respiratory volumes, we hook up the patient to a spirometer. We either put a clip on the nose or ask the patient to hold their nose, and then ask the patient to inhale and exhale, and all of that will be recorded on a graph. The reason to prevent for the nose clip is to prevent air from flowing through the nose. We want to capture all of the air as it flows through the oral cavity. Now here are the respiratory volumes and capacities, and know that this is important for both lecture and lab. And again, we measure the different volumes through spirometry. For these volumes, you want to be able to identify them or define them. You won't be responsible, though, for like the lung volumes in millimeters. Okay, the first one, and that's the most basic, is the tidal volume, which is the normal inhalation and exhalation at rest. After a normal inhalation, the maximal amount of air that the person can inhale after that is known as the inspiratory reserve volume. Both of them together, the tidal volume plus the inspiratory reserve volume, is known as the inspiratory capacity. So the inspiratory capacity is defined as after a normal exhalation, what is the maximal amount of air that a person can inhale? And that would be, again, you would inhale the tidal volume followed by the inspiratory capacity, followed by the inspiratory reserve volume. Now, the expiratory reserve volume is the amount of air that a person can exhale after a normal exhalation. So you exhale normally, and then you try to blow as much air as possible out of the lungs. That is the expiratory reserve volume. Now, the vital capacity, and that is really the volume that is of the most clinical importance. The vital capacity is when you ask the patient to inhale as much as possible and then exhale as much as possible. That is known as the vital capacity. Again, so it's basically the maximal amount of air that a person can exhale after a maximal inhalation. So again, you ask the patient to inhale as much as possible and then to exhale as forcefully as they can. Okay, so again, the vital capacity. The residual volume, that is the amount of air that will always remain in the lungs even after a maximal exhalation. So no matter how hard a person exhales, there is always going to be some air that remains in the lungs, and that is known as the residual volume. It prevents the lungs from collapsing. The functional residual capacity would be the amount of air found in the lungs after a normal exhalation. So that includes the expiratory reserve plus the residual volume. The total lung capacity is the maximal amount of air that can be found in the lungs after a maximal inhalation. So you ask the patient to inhale as much as possible. The amount of air found in the lungs at that time is known as the total lung capacity. So it pretty much includes all of these different volumes. And you can see here that a volume is just a singular part of the graph, while capacities involve two or more volumes added up together. A spirometer can pretty much identify these different volumes, but it cannot measure the residual volume. So a spirometer can measure the tidal volume, inspiratory and expiratory reserve. So you'll be able to calculate the vital capacity, or you can measure the vital capacity using the spirometer. But because You cannot measure the residual volume using the spirometer. You won't be able to measure, for example, the functional residual capacity or the total lung capacity using a spirometer. Now here are the different volumes. You can see the descriptions. Again, you are to know the definitions of them, not the actual volumes. The 3 respiratory volumes, the tidal volume, inspiratory reserve, and expiratory reserve, can be measured with a spirometer, vital capacity as well, but the residual volume cannot. Okay, remember that the respiratory capacities are calculated by combining 2 or more of the respiratory volumes. Now for dead air spaces. What are dead air spaces? It means it's a space, going from the trachea all the way down the bronchial tree, where even though they are full of air, but there's no exchange of gas. So we call them dead spaces. Part of the dead space is normal, is anatomic, because these structures were not made for gas exchange. For example, the trachea, primary bronchi, secondary bronchi, and as you go down the bronchial tree until you actually reach the where exchange of gas happens. Okay, so that anatomic space is really made out of the respiratory tract, where their main function is conduction of air. So that is your normal anatomic dead space. When we are diseased, for example, if there is a disease of the alveoli leading to the destruction of the alveoli, or maybe the alveoli is fine, but there's not enough blood supply coming there, so there's no perfusion of blood, there is a disease of the capillaries. So now, even though the alveoli should not be a dead space, but due to a disease in the alveolus itself, or the disease in the capillary supplying it, that can lead to what is known as alveolar dead space. So this is usually pathological. The physiological dead space, under normal circumstances, should be equal to the anatomic dead space. But if the physiological is more, okay, so if you add up the alveolar dead space, normally it should be 0, but if it's not, and you add it up, where now your physiological dead space would be equal to the anatomic plus alveolar. Okay, that means that there is a pathology going on, either the pathology is in the alveoli or in the blood supply to these alveoli. So again, under normal conditions, anatomic dead space is equal to the physiologic dead space. Different things that we use in order to measure alveolar ventilation. The first one, which is not very specific, is known as the minute ventilation or the minute respiratory volume, which is basically how much air is being moved in the respiratory passages per minute. And we measure that by multiplying the tidal volume times the respiratory rate. But because most of the air coming in is actually remains in the physiological dead space, which means it really is not a true representation of gas exchange. So we are going to subtract that physiologic dead space, and that leads us to a better way of measuring alveolar ventilation, known as the alveolar ventilation rate, which is basically the minute ventilation that we calculated up here minus the physiologic dead space. Okay, this is the volume of air that actually reaches the alveoli per minute. It's an important value because it's more clinically significant, and it really impacts the concentration of oxygen and carbon dioxide that's found in the alveoli. Well, now that we know all about breathing and the different breathing movements, our respiratory system does what are known as non-respiratory air movements. For example, sneezing and coughing, laughing and crying are all functions of the respiratory system. So take a look at the mechanism and the function of each of them. Coughing and sneezing are pretty much have the same way of happening, where we take a deep breath in, the glottis gets shut down, and then all of a sudden it opens up, and that will lead to the expulsion, that sudden release of air. Okay, coughing clears up the lower respiratory passages, while sneezing clears the upper respiratory passages. So that sudden blast of air would have to somehow go through the nose to clear the upper respiratory airway. And it does so, the air is kind of detoured towards the nose in sneezing by the uvula. Now, laughing and crying, they both happen in the same way, where we take a deep breath and then we release that breath in a series of kind of interrupted expirations. But obviously one of them expresses happiness while the other expresses sadness. Hiccups, we know what happens, but we don't really know what is the function of hiccups. So the diaphragm has these spasmodic contractions while the glottis is closed. That would be what a hiccup is. Yawning is taking a deep breath in. Again, we don't know why we yawn. Speech, that is for us to be able to verbally communicate together, where we force air through the larynx and then we use the vocal cords. We use other organs as well. So we use the tongue, the lips, the soft palate, the cheeks. All of these work together in coordination to perform speech. Some of the clinical applications in the respiratory system that are extremely important are bronchial asthma and emphysema. And they're important because, unfortunately, they are common. Bronchial asthma is an allergic reaction that happens to allergens. For example, if a person inhales pollen and they're allergic to pollen, and their airways are hypersensitive to it, the airways are going to respond to that allergen in 3 different ways. So there's bronchoconstriction. The bronchioles are going to constrict. There's also inflammation that's going to happen. So there's edema and swelling of the bronchi. And there's also increase in the production of mucus. Okay, so, a lot of the allergy medications tend to act on one of these 3 different things. Emphysema is another important pathology of the respiratory system. And what happens in emphysema is, if you guys remember when we talked about normal exhalation, that is due to the elastic recoil of alveoli. Well, in emphysema, patients have lost that elastic recoil. And the alveoli can expand, but it doesn't get rid of the air that's inside of it. It loses that elasticity. It keeps on expanding with air, and can keep on expanding further and further until the alveoli can get destroyed. And you have these like clusters of alveoli that merge together to form this large bolus of air. Okay, there's obviously, due to the loss of functioning alveoli, there's a decreased surface area for gas exchange. The patient finds that breathing has become is an effort for them. And emphysema is one kind of COPD, or chronic obstructive pulmonary disease. Chronic bronchitis would be another kind. In some patients, most of the time they are in combination together, emphysema plus chronic bronchitis. In the next part, we will be talking about control of breathing.